So this video refers a little bit back to my previous video when we got a little bit into the fundamentals of movement. So if you look back at that video, you can see the kind of hierarchy that I sort of made to start thinking about how to think about movement, starting with the very low resolution fundamentals of health, which include, diet and sleep and all those important things that we need to function at a higher level. And then above that, the fundamentals of movement. And that's kind of where PT and rehab sort of sits, working on the fundamentals of movement, which would be the mobility side, where it just allows kind of what I call the hardware to occupy a particular position for a particular task, like what's the hip doing when we're squatting versus what's the hip doing when we're running. The second piece was the control, which is really just the coordination around the joint so that the core muscles kick in first and then the global muscles move to actually move the joint. And then the last piece was motor control, which is kind of the expression of those two things to do a task. So when it comes to treatment, how do we address those things and what are the priorities we set whenever we start addressing? Because you can find stuff on everyone. No one moves perfectly. So we want to be as efficient as possible with our treatment. So where do we actually start intervening? What are the important things to address, and what are the things that maybe don't matter as much for what that client is concerned about? So of course they don't want to come forever, and we want to be as efficient as possible. So we need to be efficient whenever we're treating them. So that's where functional testing becomes important. Many exercise-based and especially manual therapy-based systems tend to get too granular and start looking at, does this little joint have this perfect slide, or can it move exactly kind of along these theoretical joint surfaces, where when you really start digging into it, there's so much anomaly in each of us that's not a very good strategy, and it gets so into the nitty-gritty that it kind of misses the point a lot of times. So instead of that kind of bottom up, where you're going from the nitty-gritty and assuming function gets better, we want to go from top down and measure function as much as we can, and then treat to improve that function. So that's always a very important component of an assessment, is the functional testing. And basically our goal is to see, where is function breaking down? Where you're most vulnerable is probably going to be where your injury is going to occur. So if in one particular position your core really kicks in great to support what the limb is doing, it's going to be much less likely, unless there's some sort of trauma, to be affected than another hip position, for example, that your core may not have good support of that leg position. And so a lot of times if we go chasing pain, we're not going to be very effective in treating it. But if we address the function, the body is going to do what it needs to do to fix the thing that hurts, because we've taken the stress away from it. So there's kind of a pre-post testing. So before we get into the nitty-gritty and say, oh, your hip is a little tight here, your core is a little weak here, and we kind of miss the forest for the trees, we want to look at function first in as many positions as these people need. And so it doesn't have to be anything special. It's really, what do people do? How did the person get injured? And that's a great place to start and see, oh, core's not kicking in well here. Oh, this appears to be stiff. And just give us clues in different positions where their function may be breaking down. So it's not giving us a whole lot of specific information. It's just saying, function is limited in X position. Then we need to go back and start correlating. What do we actually, when we lay them on the table, what do we find? Oh, it appeared that when you squatted, you kind of shifted off that right hip, so maybe it's a little tight. Now let's actually go and look at the hip and start correlating what do we find clinically with what we're seeing functionally. And then that gives us a good place to start intervening, so that once we treat, we're not just treating in isolation saying, oh, this joint needs to slide this much or this needs to rotate X amount, that we can actually treat the thing and then go back and look at function and see, did it actually change? And that's a way to start indirectly treating pain when treating pain directly is usually not as effective. So I really encourage functional testing prior to or as a part of our evaluation and ongoing treatment. We should be constantly evaluating function so that pain many times can then take care of itself as function improves. We'll have the benefit of improved function, so that may be strength or endurance or whatever task you need to be doing. Maybe that's just going to the store without getting out of breath. So you'll have that improved function, but you'll probably also have an improvement in pain, where the vice versa is not always true. If we're just using, let's say, a steroid injection to reduce pain, that doesn't guarantee that function will improve, and often it doesn't. So treating for function is the big key, the takeaway to this video, and that goes even into treatment. We need to look at function, but we have to treat deficits, of course, but then go back to function and measure and see, did we actually influence that or not? And then that's kind of how we use that to drive treatment. If we've treated a stiff hip but it's not influencing their function in the particular need that they have, then we probably need to go another direction. Thanks for watching. I'll include the last video in the notes so that you can check that out if you want.